we'll expand on that. Just an overview of this talk. The phases of recovery after hip arthroscopy have been, in most literature, divided into 4 phases. So we'll kind of break this talk down to that and then talk a little bit more about return to sport. So the importance of rehab, these are kind of things that I've kind of grasped out of the overall kind of in doing background research of this, but it's almost like a neuromuscular reset button. After a hip arthroscopy, patients, essentially all their muscles have shut down and been inhibited. Maybe they did have a muscle imbalance before, they got them in trouble, especially in maybe instability, and that kind of, now they've kind of hit a reset and they can go into physical therapy and strengthen those muscles that probably weren't strong to begin with. Poor gait and the importance of rehab in that early phase can cause joint irritation, so there's kind of a balance between pushing and not pushing hard enough for your rehab. And then for return to sport, rehab is obviously very important, but the most important thing probably is muscle performance and the ability to protect the life of your hip, because now that you've put a scope in it, it's not your hip, so you want to protect it. The rehab can be your best friend. So phase 1 is typically 1 to 2 weeks. The goals are to protect healing tissues, restore independent mobility but with an assistive device, begin past the range of motion within range of motion guidelines, diminish pain and inflammation, and prevent muscular inhibition and any gait abnormalities that might come out of that. So the tools we have are braces, crutch, CPM, isometrics, and manual techniques. Kind of go into those in a little bit more detail. So bracing functions to restrict range of motion. Not everybody does use a brace, as I alluded to earlier this morning, but it's consistent with phase 1 goals, which is to protect healing tissues and limit range of motion, which protects the tissues. So weight bearing, these are how our patients in LA present after hip arthroscopy. Partial weight bearing on crutches. So typically 20 pounds for about 2 weeks. In the non-weight bearing, can activate hip flexors and compressive loads across the joint at a time where you're trying to protect the joint and any intra-articular work you've done. So partial weight bearing more important than non-weight bearing. Richard Villar did a study looking at our crutches required after hip arthroscopy. He had 2 groups, one that was required to use crutches for 4 weeks, and then another group that was allowed to use them PRN. The 4-week group used them for 28 days, so they were tolerant, and then the other group actually ended up using them for 2 weeks. So, you don't have to say you need crutches, but they'll probably use them for about that time anyway. So it's an inherent phase 2 situation, I guess. And so there's no difference in outcomes in the Harris-Hip score in those 2 groups as well, 6 weeks and 6 months. So modifiers to the weight bearing, if you do a microfracture, you're going to probably protect them for 6 to 8 weeks unless somebody is very opposed to that. I tell them it's their hip, but I try to push them. We've had that conversation a couple of times already. Gluteus medius repair, we talked about earlier this morning, 6 weeks of non-weight bearing or partial weight bearing. Capsule plication, perhaps if it's very highly unstable or you're not confident in your repair, you might protect them for a little bit longer. So passive range of motion, kind of 2 ways to get this going in phase 1, a CPM machine. Try to start it the next day, 4 to 6 hours. It's been written somewhere 4 to 6 hours per day for 3 days. And then only 1 or 2 hours for 2 more weeks. I think basically some people are using this up to 6 weeks. Circumduction, which has been advocated to prevent adhesions, is important. And then prone lying, where patients just lay on their stomach for about 2 hours a day. So the kind of guidelines for range of motion, flexion to 90 degrees, this is all for 6 weeks. Flexion 90 degrees, extension to 0, abduction 20 to 25, internal rotation 0, and external rotation about 30 degrees. The extension of 0 degrees, that's what's written in several places, but there's a little bit of a hiccup there because normal gait requires 10 degrees of extension. So I think you're not going to push for minus 20 degrees of extension, but you got to give them at least that 10 degrees. So preventing muscle inhibition, main thing is to activate the gluteus medius, but at the same time preventing iliopsoas tendinitis. You're working on your deep core musculature at that time. So most importantly, you're doing isometric exercises, quad setting, gluteal setting, transverse abdominis, safe exercises that Philip Hahn indicated in an article in AJSM was double leg bridges. That works on extensors. That's actually been shown to be inhibited after an arthrogram, so just injecting fluid into the hip will inhibit the hip extensors. Easy things to do is resistant terminal knee extension and knee flexion, so you're minimally involving the hip in that situation, but activating other muscles that will help in gait. And then prone heel squeezes, working on excellent rotators, which are important for hip stability. So phase 2 begins at that 3 to 8 week mark, or that 2 to 3 weeks after they've gotten rid of the crutches. The main goal of this is to restore normal gait. So they've had muscle inhibition to a certain degree. You're trying to get them back to full weight bearing, restoring range of motion, gait, and working on progressive strengthening. Precautions in this phase are no forced aggressive stretching of any muscles, and trying to avoid inflammation of the hip flexors, adductors, all the muscles around there. So it's a balance between too much force and not enough rest. You don't want to aggravate muscles, tendons, or the joint itself. Still, at this point, you're not going to want to use a treadmill. Several authors have advocated treadmill use to being bad throughout rehab. Probably don't want to ever get back on a treadmill for these guys. So, kind of a review on the normal gait, as I mentioned. Sagittal plane range of motion for normal gait is about 40 degrees of flexion, 10 degrees of extension. You want to work on strength and endurance throughout this range for that phase 2. Hip extensors are active in heel strike, and hip flexors are active in swing phase, concentrically eccentric during the stance phase. For hip extensors, you're going to do single leg bridges, deadlifts, hamstring curls, and the therapy ball. I probably wouldn't recommend deadlifts to patients, but that's been written. And you want to avoid extension beyond 10 degrees as you're still trying to protect your repairs while restoring gait. There's also a kind of a bit of a hiccup regarding hip flexors. You don't want to obviously cause any iliopsoas tendonitis, and that's been talked about quite a bit, but the swing phase of gait, you have to activate your hip flexors. So probably for gait it's okay, but for active resistive strengthening, you don't want to really do that. In the coronal plane, we've talked about it before, the hip abductors and their role in the abductor or Chenellenberg gaits, very important. So single leg squats are the main thing that helps in gait in the stance phase. So other activities, so you can use stationary bicycle for 6 weeks, I guess CPM as well, but at that point it's probably better to advance to the bicycle. In phase 2, you're working on full range of motion. Other things more, your cardiovascular fitness, you're going to try to restore that now by using upper body strengthening bicycle, other things. Pool running, some people talk about beginning pool running at this towards the end of this phase, starting in deeper water and advancing to more shallow water. I guess if you're Kobe Bryant, you can have anti-gravity type thing, but then you're on a treadmill, so I don't know where that lies. And then just some exercises. We don't need to bog ourselves down with all those things that they're doing in the PT area. So the criteria to advance from phase 2 is pain-free gait and a normal gait, full range of motion with only mild stiffness and external rotation. Successful initiation of functional exercises with no pain and good numerical control, and they can go to phase 3, which is the advanced rehab, starting around 9 weeks to 12 weeks. The goal to restore muscular strength and endurance, also continue to improve your cardiovascular endurance, and then kind of begin sport progressions. And again, you wanted to avoid hip flexor and adductor irritations, still avoiding high contact activities and aggressive stretching. So some of the tools you have for the phase 3, still doing circumduction, prone lying, soft tissue, so not much has changed from phase 1 and 2, but you're adding sport progression and functional activities, going from double leg strengthening to single leg strengthening. Criteria to advance to this is these exercises form in a pain-free, correct form. So advancing a patient in the clinic is almost impossible. That's something the physical therapist does. There's also something called the sport test, not validated to my knowledge, but it's been written. It consists of a single knee bend. You hold that for 3 minutes, and you get 1 point for each 30 seconds. Lateral agility, there's some diagrams in this, but you can imagine what it is. Basically jumping side to side to a certain distance. If you do that for 100 seconds, you get 1 point for each 20 seconds. Diagonal, just kind of going, back kind of in a triangle shape. Again, 100 seconds, 1 point. And then forward lunges on a box, hopefully not going too deep in the lunge. So a passing score being 17. I don't know if a lot of people use this, but it's written and it's something maybe therapists are using. I haven't heard of anything from them. So phase 4 is kind of the return to sport. So now you're talking to the patient about 3 months out, and they're anxious to get back to play. So that's kind of the goals here. Not a lot of precautions, and hopefully they have advanced through all the other phases, and that's it. So one of the main benefits, or the main points to this phase 4 is the long-term care of the hip. So restoring that muscular tone and creating good habits so that patients are doing hip exercises like they're brushing their teeth. So almost every day. Maybe I tell patients to pick 1 or 2 and do them every day. So PTs need to develop a sport plan, specific sport training and conditioning, work on power training, plyometrics. The criteria to advance out of this is cleared by a physician. Again, I don't know how I would clear a patient in my office for returning to play. I'd pretty much leave it in the hands of the therapist, but certainly if you can talk to them and have an open dialogue with the therapist, that'll help tremendously. So some data on return to sport. This has been mentioned before, but Kelly had a paper showing 79% return to sport on an average of 9.4 months. So if you look at the range, you have 4 months to 26 months. I'm not sure what happened to after from 25 to 26 months in that patient, but maybe it was contractual. That was a mixed group of patients. Philippon reported 93% success rate, didn't report a time to getting back to the sport. And Bird showed 95% professional, 85% collegiate, and that just kind of demonstrates the impetus for return if you're getting paid versus not. So basically what I tell patients at pre-op visit, I go through an overall, talk about the procedure, risks, etc., but then I talk about the rehab because it's such an important part. I want them to know what they're getting themselves into. And then I say the first 2 weeks, you're just relaxing, it's pain control, wear the brace, ice, use the crutches, instruct them on how to use crutches, because I don't know that it gets conveyed to them to put your heel down. So I want to make sure I tell them that. And then I see them at 2 weeks post-op, and at that point, so I'm seeing them at almost the transition from phase 1 to phase 2, phase 2 to 3, 3 to 4. So in 2 weeks now they're going into phase 2, and I just tell them their main goal is to restore their range of motion and walk normally. So then as I have them come back at 6 weeks, and the first thing I'm checking is them walking. I had a girl who was limping tremendously at 6 weeks, so I can tell she's probably not going to do well. Range of motion was also poor. Another guy comes in and he's walking down the hall perfectly fine. So it's there's not much to do at 6 weeks. It's kind of a hello visit, but you can get a good gauge on where they stand and how they're going to progress from there. And at that point, you just emphasize moving forward, they're going to work on their strengthening. So then I see them at 3 months, and at that point, they're usually pretty happy. And you want to promote kind of return to sport, so you kind of coach them on pushing their strengthening, but not pushing too hard so they irritate the joint or cause any pain or problems to return. And then if they ask, when will I be able to play, and I usually say about 6 to 9 months. They usually tolerate that pretty well. So in conclusion, rehabilitation after hip arthroscopy is a big undertaking. I kind of alluded to during the moderating that some patients, you tell them 6 weeks and on weight bearing for a gluteus medius repair, and they might say, well, it doesn't hurt that bad. Normalization of gait is very important. There's a balance between strengthening and aggravation of the hip, and return alternative sport is possible, but at what cost to the life of the hip?